So we'll go ahead and get started. I want to welcome everyone to Medical Grand Rounds at the University of Colorado. I will keep saying this. We're very pleased to be back in person, and I am not lying for those of you on Zoom. We have a very packed room, so really encouraging everybody. We will keep the Zoom link open for the entire year, but I would like to have everybody back in person if we can, for as long as we can possibly pull this off. So we will be in RC2 in the Krubin Conference Room, but again, on Zoom throughout the year. Upcoming talks, September 7th next week is Dr. Sean Davis discussing the power of cloud computing and the analysis of genetic data to improve patient care. And then on September 14th is Dr. John Messenger discussing transcatheter interventions for valvular heart diseases. As a reminder, there is CME and mock credit for all grand rounds through the Department of Medicine, which you can get by clicking on this QR code or the one that was sent to you in your email. Questions this year are going to come from our live audience as well as the Zoom audience. The chief medical residents will monitor the Zoom chat. I'll be here live, and we'll make sure to have an interesting conversation at the end of grand rounds. And now I really am pleased to welcome our two speakers on a very special and timely topic, Dr. Karen Wendell and Dr. Andres Henao Martinez. Dr. Karen Wendell is the Director of HIV and STD Prevention and Control at Denver Public Health and Denver Health, and an assistant professor of medicine at the University of Colorado Health Sciences Center Division of Infectious Diseases. She received her medical degree from Johns Hopkins School of Medicine and completed her internal medicine training, her internship, residency, and infectious diseases all at Johns Hopkins Hospital. She's been involved in HIV and STD clinical care and research while on the faculty at Johns Hopkins, Oklahoma Health Sciences Center, and the University of Colorado. While in Baltimore, she served as the director of the Early Intervention Initiative for HIV Care for the Baltimore City Health Department's STD clinics. And while in Oklahoma, she was the medical director for the Oklahoma City County Health Department STD clinic. She joined the University of Colorado faculty in 2015 and now serves as assistant professor of medicine, works clinically at Denver Health, where she oversees the Denver Sexual Health Clinic, the Linkage to Care program, the HIV and STI outreach services. And Dr. Andres Henao Martinez is an associate professor of medicine here at the University of Colorado as well, also in the Division of Infectious Diseases. He completed his medical school training at the Universidad de Valle in Cali, Colombia, his internship and residency at the University of Texas Health Sciences Center at San Antonio, and his infectious disease training here at the University of Colorado, where we've been lucky to keep him on faculty since 2015. He's also been the director of the residency, travel clinic at the University of Colorado Hospital since 2016, and he directs the outpatient infectious diseases rotation for the internal medicine residents, as well as the preventive medicine fellowships. His research interests are in the study of host susceptibility factors to different fungal and tropical infections. He's a national infectious diseases expert, also serves as the editor-in-chief of the Journal of Therapeutic Advances of Infectious Diseases, and has over 100 publications to his name. I really am pleased to welcome both of these speakers, and I am very grateful that they were willing to do this on pretty short notice and put together a medical grand rounds for us on this emerging infectious diseases topic, which has affected about 50,000 people worldwide and over 18,000 in the US to date. So it looks like we'll start with Dr. Henao Martinez.
Well, thank you very much for having me. I think it's a pleasure. And Karen and I want to cover this kind of emerging topic of monkeypox. Obviously, we cannot catch a break in ID. We have a new year, new disease. We'll see what the new year will bring. But, we want to kind of give you an update of what is, as a clinician, we need to know about monkeypox. And keep in mind that, we, as the, outbreak evolves, we might gain, new knowledge, and things that we might be telling you today might not be, accurate in a few weeks down the road. So no particular conflicts to disclose. And just going through the objectives, basically trying to recognize the most predominant epidemiologic factors that are related to this emerging outbreak, and kind of going through the most basic clinical features and consideration for differential diagnosis, as well as key tools for diagnosis, treatment, and prevention. This picture is from what monkeypox looks like before this year. It's a disease that affected children in Africa, and we'll touch base on those in a second. So I'm gonna start with a case. This is a patient that actually came to our clinic, 36 years old man, pre-acute illness. And this is something that you might recognize, you might wanna encounter in the future. So body aches, fever, very non-specific symptoms, a little bit of rectal pain with some bleeding. He had a history of HIV, well controlled on therapy, and apparently some sexual assault, although the sexual history wasn't as clear. He wasn't comfortable giving all the details. So keep in mind this case, because obviously we all recognize monkeypox by the rash, but occasionally we want to see that some cases will present earlier, and having a high index of suspicion is very important. So this is what the map looks like today. This is from the CDC and is numbers from 2 days ago. As you see, more than close to 100 countries are affected already. The blue dots is where the monkeypox originally is endemic in Central and West Africa. But the total cases now reaching 50,000, with 80,000 here in the US. The first outside endemic areas cases were recognized in the UK in May 6, but shortly after here in the US in May 18. And finally, the WHO declared the public health emergency on July the 23rd. And this is data from the WHO. It's kind of hard to tell where this outbreak is going to behave. There is some probably numbers, especially in Europe, that seems to be that the cases are decreasing there, but overall, still we're seeing plenty of cases, especially in the region of the Americas. And this is a table where you can see that the cases are kind of plateau decreasing in Europe, but it's still increasing in the United States. And it might be because we're a little bit behind, since the cases were starting in Europe first, but also speak a little bit of maybe not as good efforts for public health measurements, and something that we also experienced with COVID-19. And so this is the map for the United States. Like I say, 80,000 cases, and so far reported close to 200 cases in Colorado. Obviously, regions with a lot of cases: California, Texas, and Florida. And this is from New York, where they have a very strong public health measurements, and we see that they have made some advances to try to control the outbreak in there with the vaccines and some changes in behavior from some minority communities. So it sounds like they are able to make some story, but that can be different in other places. And this is also a wastewater surveillance system. And this West African clade is the clade that is culprit for this ongoing outbreak. And so you can see the numbers are kind of plateau a little bit, but it's still a fair amount of viral detection in the community. So going back to the basics, monkeypox belongs to the genus Orthopox virus. It's a group of large, complex, double-stranded DNA viruses that replicate in the cytoplasm. The most four common human viruses are variola, was the causative agent of smallpox that now was declared eradicated by the WHO in 1980. Also cowpox, very rare occasional cases, vaccinia, which actually was a virus that was used to develop the vaccine against variola, and now the monkeypox. And you can see there electronic photo of the vaccinia virus. But this group obviously is larger, and you can see that there is a different type of species that affects not only humans, but other mammals, rodents, and cattle. And so, like I mentioned, important for us to recognize the variola and the vaccinia, kind of historically very well known to humans, but also now the cowpox, which has caused very sporadic cases, also affects cattle, elephants, and rodents. But now the monkeypox, which affects not only humans but other mammals listed there. And if you listen to this guy, maybe whelpox might be also another one. So going back a little bit to smallpox, and I don't want to spend too much time here, but it's a disease that was again considered eradicated by the WHO in 1980, but it's been devastating humanity for so long, has killed more than 500 million people, and that was the first infection where we have development of a vaccine. And the last case was reported in 1975. This was actually a successful story with a very disease that was causing so much burden, and it speaks as good efforts when really we kind of emphasizing global health and having pretty strong public health measurements, which unfortunately is not the case in 2022. This is the monkeypox in reality is part of how we been neglecting global health. Is monkeypox, as you know, is being with us for 50 years. 50 years. It was initially described in humans in 1970. And it's been causing some burden in Africa, especially in African children, over the last decades. And we haven't had put any effort to contain or have tools to prevent and treat this infection, unfortunately, because it's affecting minorities. So as you can see, this is kind of the disparity and what we're talking global health, a little bit of the equity that we need to kind of put emphasis when we're doing global health is now that there is so much attention in monkeypox. You can see that there is a lot of effort and tools available for those countries where they have now received vaccines. And you can see now African country hasn't received any vaccine. And they see the most of the burden is still with the infection, like I mentioned, 70 deaths. And this is a very good editorial in Nature that kind of point out to that inequity. And again, looking at opportunities that we have missed, and is that with monkeypox that has affected children in those countries, and not only causing morbidity but also mortality. As you can see, the numbers for the two different clades that are affecting Africa over the last decades. And so it's monkeypox today, but it might be something next year, something else. So monkeypox, is kind of still in study why it jumped from being, endemic in Africa and now being more affecting so much countries. There is some phylogenetic studies that show that there is some changes in 50 SNPs that might be driven a change in this apolipoprotein B that might be causing a little bit more accelerated evolution. Is anybody interested a little bit more? They could go to this website and kind of look at how these new strains are evolving based on the ongoing outbreak. And you can see in red what the original strain originated in Central and West Africa, and now the different strains that are affecting North America and Europe. So originally, this is kind of the genetic clades, the West African clade, now renamed by the WHO as clade 2, affecting those countries listed there, and the Central African clade, clade number 1. And you can see Cameroon is kind of overlapping between the two. The Central African clade is more infectious and also has an increased fatality rate. And after that was discovered endemic, there were some important cases locally to other countries, especially Benin and South Sudan. And we have seen cases of monkeypox, very sporadic cases, important to consider in 2003 and 2009 were important cases to the United States from some animals, wild animals, prairie dogs that caused some kind of limited outbreak, and also in the UK. And so this is kind of the monkeypox virus kind of runs in nature. There is different potential host. As you see, despite of the name monkeypox, primates are not the only one, and mostly are present in rodents. And so there were some efforts to kind of rename the virus, but is now, still very recognized as monkeypox. And then humans becomes a host, accidental host, either initially as a primary infection when manipulated and contaminated, infected animals or animal products. And once it's in human, it can have a secondary infection and transmission from human to human, even from mom to baby. So this is the mode of transmission. You can have unprotected contact with respiratory droplets or lesion materials or body fluids through either the respiratory tract, mucous membranes, and keep this in mind, mucous membranes is one of the most common port of entries, and that's when you're gonna examine and see for lesions, because that's been commonly represented in this outbreak, or through broken skin lesions. So going back to the case, when he presented, the diagnosis wasn't differentiated. We had a suspicion, but we still didn't know what it was. But 2 days later, the rash appear, which facilitated the diagnosis. And this is actual pictures from that patient. And you can see the rash there can have different characteristics. If you swab the lesions, that for that patient came back positive for monkeypox. He continued with some rectal pain concerning from proctitis, so he was starting tocopheromate. And 5 days into treatment, he really quickly recovered. So I want to just touch base essentially on the demographics of this monkeypox infections. Affects men overwhelmingly, more than 99% of the time. There are cases, obviously, of women, but they are rare. And again, just to point out here that it's kind of a deja vu over again. We have seen it with HIV, we have seen it with COVID-19, and again, we're starting to see it with monkeypox. There's some disparities and some minority groups disproportionately affected by this, especially Hispanics and African Americans. So that can be obviously lead to social determinants of health. That can be clue when you see those differences in clinical practice. And so when you talk about exposure history, again, men who have sex with men are a high risk factor, and having more than one partner also is very common. And the hospitalization rates here was 8 days. And this report from the CDC actually didn't report any deaths. And so this is what it happens with monkeypox. You normally have an incubation of 5 to 21 days, so you can still have 3 weeks where you don't have any symptoms after you've been exposed. And then you kind of have quickly develop this acute febrile illness that can last from 1 to 4 days. And also you can have lymphadenopathy, which can be a clue diagnostically, headaches, and some other non-specific symptoms. And then the rash appears, which is going to help you a lot with the diagnosis that occurs about 2 or 4 weeks. And then later you will have a full recovery. And so again, to kind of stress out the most how the disease progress, you can have fever and lymphadenopathy. When you have in this stage, you're going to have a high viremia, and you're going to be able to detect the blood in the virus in the bloodstream. And then you develop the rash. This is actually from a case report that we presented, we published, and you can see lesions affecting the genitalia, but also other body parts. And as you can see, one of the lesions, you can have a little bit of superimposed bacterial infection or cellulitis that sometimes can come from manipulation of the lesions. So this is how the rash evolved, some macules and papules that initially can be a little bit challenging to diagnose too, because they might look like a lot of different things. But once they develop into vesicle and pustules, they might become a little bit more apparent, and your differential diagnosis is narrow. And finally, they can cross. And so this is a report from the Lancet, and you can see this in the rash stage. You can still detect, you can still have a little bit of viremia, but more important, you're going to be able to detect the virus in those lesions. Keep in mind, again, the rash affects mucosal areas, so you want to expect, oral, genital, perianal areas for lesions, because that's mostly of the port of entry, and that's where you want to do a close examination. And this report, again, from the Lancet to mention, obviously, mostly men who have sex with men. The proportion of HIV positive patients was 40% on this report. Very non-specific symptoms initially, but the lesions probably more were multiple and affecting, again, the genital region, and lymphadenopathy can also give you a clue. This is a report from the New England Journal from multi-site country report from 60 countries. Again, kind of the same characteristics so far. Keep in mind, this also happened with HIV in the early stages, that there was a population initially affected by this, but as the outbreak evolved, you might see different population that can be effective in different ways. So this is true today. It may change. And this is more for endemic countries where you can, have a little bit of differential diagnosis, especially for chickenpox and measles, that there is a little bit of distinctive appearance in the rash and the fever that can kind of clue you in about what to look for in the differential diagnosis for those. And so also the rash may have different characteristics, but Karen will touch base a little bit more on more of that differential diagnosis. And just kind of finalize this part of the clinical presentation, keep in mind the complication can be frequently encountered. When you have lesions around the eye, you can have corneal infection or vision loss. If affects, penis can have phimosis or paraphimosis. We mentioned proctitis, as we described in the case, tonsillitis, cellulitis that can lead to sepsis. In the original cases, there were also cases of airway obstruction and pneumonia. Encephalitis is extremely rare, and this other complication hasn't been reported in this kind of Europe and US outbreak. And this is kind of the proportion of complication reported in Lancet. So proctitis, relatively common, as well as tonsillitis, something to also keep in mind. This is a little bit of unpublished data I'm going to share with you. We're looking at close to 300 cases of monkeypox through different sites. And just to keep in mind that most people will present through urgent care or ED, so having those people trained is key. And as we have seen as infectious disease doctors, we get a lot of calls from those sites because they are most likely the providers that are going to encounter those first. And again, relatively low rates of complication, but something obviously to keep in mind. And then, we're looking a little bit of what may predispose somebody my risk for a hospital admission, and obviously complication, a little bit more systemic symptoms, and increasing LFTs and cytolysis might be factors that can be predictors of hospitalization with this disease. And just to touch base on mortality, we haven't seen deaths yet, although there is one case that's been on study in Texas. But we have seen reported some deaths already in non-endemic countries with different fatality rates. This is some editorial we put together. But obviously the fatality rate is being reported higher for the endemic countries as well. And with that, I'm going to pass along to Karen.
So I'm just finishing out my COVID isolation, and we'll see if I make it through this. My cough was perfect earlier. So I'm going to talk a little bit about diagnostics, therapeutics, and prevention. And to start out, I just want to go over that what we're seeing here in the United States and Europe with this new monkeypox outbreak looks somewhat different from that classic presentation that Andres presented, in that oftentimes it doesn't have the prodrome, and patients are presenting sometimes just with the rash. Sometimes they have a single genital lesion. Sometimes they'll have 10. And really, in fact, the majority are going to have that low count of lesions. And when they present, it can be somewhat difficult to know what's going on because the lesions can also be at different stages of maturation, which is not something that we thought of characteristically with monkeypox in the past. So another atypical feature that we're seeing now, and Andres touched on this, is proctitis. And many of the patients that we see with proctitis don't have other skin lesions, making it extremely difficult to make the diagnosis. So we need to keep all of these things in mind. And what does it really mean about what's going on with monkeypox? Do we now have sexual transmission? I think clearly we are having sexual transmission, but what we don't know is it because of presence of virus in the semen or in the vaginal fluid? Where is the chief amount of transmission occurring? What are the fluids that are involved? And what are the best mechanisms to stop that in the future? So as we think about the current presentation, it's really important to think about it in a broad differential of sexually transmitted diseases. When we look at these cases now, it can sometimes be very challenging to tell them from other cases of STIs. And when we think about them, especially for the rash, the things that we think of in the differential are herpes. And we've been fooled. There have been lesions that the entire group at Denver Health Infectious Disease looked at and said, that's monkeypox. And it turned out to be herpes simplex. The key element here is that you have to do all the testing. And so thinking about herpes simplex, syphilis, certainly in primary as a single genital lesion or even multiple genital lesions. We know that syphilis is presenting in that way frequently now. Lymphogranuloma venereum, which also can be that ulcerative presentation with lymphadenopathy, disseminated gonorrhea with these hemorrhagic and pustular acral distribution of rash, varicella zoster, or some disseminated fungal infections certainly can look somewhat similar. But then the proctitis, to think in your differential and to keep all the testing at hand to look for gonorrhea, chlamydia, syphilis, herpes, and again, lymphogranuloma venereum. So as we think about this, there have been over 200 diagnoses here in Colorado. At Denver Health, we've seen about 90. We need to keep in our big view the fact that we are also in an STI epidemic, and we're seeing the highest numbers that we've seen in years in chlamydia, which is up 1.2% since 2016, gonorrhea up 45% since 2016, syphilis up 52%, and unfortunately, congenital syphilis up 235%. So as we were looking at this at Denver Health, we really thought about this as not just testing for monkeypox, but making sure that all the clinicians had the tools to test for everything that would be potentially in the differential. And certainly not for every client, right? So there are going to be clients that come in with a lesion on their leg, don't have any sexually transmitted history risk factors, but maybe had close skin to skin contact with someone at the gym or something else. They don't necessarily need STI testing. So I think we do need to use our clinical judgment. But for most cases, it's important to think through our list, thinking about acute HIV, thinking about not only an antigen antibody test and HIV RNA testing, but HSV PCR, gonorrhea, chlamydia at all sites of exposure, syphilis either by EIA, so enzyme immunoassays or chemiluminescent assays, RPR, or when needed, testing for lymphogranuloma venereum. So when do we do that? We do that when we're looking at somebody who has proctitis and their chlamydia test is positive. We will send an LGV at that time. In the last couple of months, we've seen 4 of those here in the Denver region. And making that something that all of the clinicians just know that is part of this process in thinking about monkeypox by making it part of EHRs and putting it in order sets. So testing has been complicated in the United States, and I wish I could say it was different from what we experienced in COVID, but I think it was very, very much the same. And unfortunately, it, in my view, continues to be so. So we are very fortunate that the CDC already had an approved 510 clearance FDA test for orthopox viruses. They had first gotten this approved in 2005. They'd done some updates in 2018 and finally had made some changes for automation in 2022. And they were able to push this out through the Laboratory Response Network and make it available across the United States. But what came with it, especially in not every jurisdiction, but in many, was a requirement to call the health department about each patient, give a long clinical history, and fill out a bunch of forms. And that process, I think, slowed down our uptake of testing and also gave an impression to many clinicians that this should be a restricted item. This should be something we do infrequently. When I think whenever we're trying to control an epidemic, our response should be quite the opposite. And so the CDC decided to move things out into commercial labs. And they did so on July 5th and started working with 5 different nationwide commercial labs. And those labs have taken up this CDC FDA approved test for orthopox viruses and have taken them into their labs and provided them without all of the hoops and whistles that we had to jump through with the LRNs. Quest is an exception, and they're using their own lab developed test. And now many of us are working with other national-based labs that have developed lab-developed tests. I think both university and Denver Health are working with Arup, who have created their own lab-developed test. And so this is what looks like our testing capacity now. So it went from that very low level for, unfortunately, over a month to rising up to 80,000 tests a day, and we're not near using it all. And unfortunately, as we talk to clients all over this state, there's a feeling that they don't know where to go, and I think clinicians still don't know how to access the testing. In addition, I think there is a lack of awareness. So we're, so happy to have this opportunity here today. So the CDC has been very vocal about recommending that we don't test too broadly because these are nucleic acid amplification tests, and there are potentials for false positivity related to contamination in the lab, contamination in the field, and specifically recommend to all labs using this assay that they developed that if they have a specimen that really requires high cycle thresholds for positivity, at or above 34, that they consider that very concerning, and that they start from scratch with an extraction and take it all the way through again to really determine whether this is a positive test. And to use a similar type of approach if a patient doesn't fit an epi profile. I think that's going to be difficult. I think the labs won't have that data. And I think that we can't be too careful because I think all of us anticipate that there could be risk of this spreading into other populations, and we need to be testing other populations. Just to go over what ARUP has been doing as a PCR test as well, it doesn't require that confirmation. When we started with the laboratory response network, they would take 2 swabs, and they would either be in viral transport media or dry swabs. The LRN that serves Colorado wanted dry swabs. And those 2 swabs, one was used for the orthopox test. The other test was really held for a monkeypox specific PCR for validation and for confirmation that that orthopox virus was monkeypox. For ARUP labs, we're just turning in 1 sample per area that we swab, and it's going into viral transport media. They are very specific, both at the LRN and at ARUP, that we can't use cotton swabs. If we use cotton swabs, you can throw away your sample. So you have to swab lesions with Dacron, polyester, or nylon swabs, and then use the appropriate transport vehicle. So a very important component of collecting these samples is vigorously swabbing. You don't have to uncap a lesion. You don't have to scrape off the top to get at that base, but you do have to scrub vigorously because all of these tests to be validated are looking for human DNA, RNase-P. And if they don't see that, they consider it an incomplete or inconclusive sample. And the turnaround test for most of these, the time has been between 2 days to 5 days. And so then if you get back an inconclusive answer, it's quite difficult on your client and also difficult to manage clinically. So very important to do that aggressive swabbing, to use the right type of swab and put it in the right type of tube. You can also use crusts, and the thing about monkeypox is that it's highly contagious, and the scabs and crusts are actually more contagious than a regular swab of a lesion. And so those crusts are loaded with virus, and you can scrape a crust into a sample if one of your labs accepts that type of a sample for testing. The CDC specifically recommends that we test up to 3 different sites on a patient's body, 3 lesions that look different ways. And certainly we've experienced many times where we thought we knew the right lesion, but it actually turned out to be another. Because of the evolution and not being synchronous, and because these lesions can look like other things, it is a good idea to try to sample more than 1 on each client. So just make sure for any patient that you're evaluating and labs that you're using that you're just following the lab-specific instructions for the place that you are testing. Importantly, before you evaluate anyone with monkeypox, you want to make sure that you have the appropriate PPE on. The recommended PPE at this time, even though we know there's very little airborne transmission, right? It's mainly large droplet transmission when we talk about any kind of respiratory transmission. However, there can be aerosolizing procedures that occur, and even a client shaking out their clothes that might be full of scabs can be enough, and has been documented to be enough, to cause infection in a healthcare worker. So we want to wear an N95 mask, gowns, gloves, and in some facilities, they've even chosen to wear footwear and eye protection. And they don't need to be in a negative pressure room. They really can be in any type of room, but you want them to be by themselves. And so typically when we're seeing these patients in the clinic, we try to screen early for any monkeypox symptoms and bring them straight back and not leave them sitting in the waiting room with other clients. And then the room doesn't really need a terminal clean. Any cleaning agent that meets an EPA-Q category is appropriate for use for cleaning the surfaces in the room. So do we have any other tests that we could rely on? Certainly we could get serology, but it's not very useful in trying to evaluate somebody with acute symptoms in front of you. There's a lot of cross-reactivity with other orthopox viruses. And so if you happen to be seeing someone who previously was vaccinated for smallpox or has received the Jenius now during this current outbreak, these tests probably won't be very useful for you. They're both IgM and IgGs available. The IgM typically starts to detect serology positive by 4 to 56 days after the onset of the rash, and IgG 3 to 7 days after the IgM. These are most useful for us to evaluate what's happening in a particular community. And so CDC is using this to really look broadly to identify how many asymptomatic infections are occurring in the US that we have not managed to pick up. As regards rapid diagnostics, there's nothing even on the table yet. We certainly would love to have antigen-based testing. Would be real useful to be able to do something quick and have an answer very quickly, but nothing that has even been submitted to date. So many of us are interested in testing things that are more than just skin for many reasons, and for better understanding of how this disease is currently being transmitted in the community. And there are several papers out there looking at samples other than skin lesions and trying to determine the reliability of testing at those sites. This is one of those papers, just looking at 12 different individuals in Spain at 2 to 3 different time periods and comparing their positivity rates in saliva, rectal swabs, nasopharyngeal, semen, urine, and feces. And you can see that many of these sample sites do quite well. So saliva in this very small study had an 86% positivity rate. Rectal swabs were 91, nasopharyngeal 78, semen 75, urine and feces 81 and 61. And so certainly many of us, when evaluating proctitis, would love to be able to do a rectal swab just like we do for gonorrhea and chlamydia. And so we really need more data so that these tests can be validated and we know what they mean. So I think that's the concern now, is knowing what they mean if there are no skin lesions. Is it a false positive? Is it somebody who's going to evolve into a 4-week-long course of rash? What do you do with this person? Do they have to be on isolation? There are many questions to answer, but to take this kind of testing that would be take out the need to see a lesion would be very useful, and would also take testing out of a clinical setting potentially and allow for testing in the field and testing with non-clinical staff. So I'd like to transition a bit to talking about therapeutics. The CDC guidance on when to consider therapeutics for monkeypox includes signs of severe disease. So hemorrhagic disease, confluent lesions, sepsis, encephalitis, or other conditions requiring hospitalization. People at high risk of severe disease that you think could progress aggressively, so immunocompromised individuals. That can include persons living with HIV. Typically, we're thinking people that are less than 350 CD4 count are at highest risk. People who are not currently virologically suppressed. Solid organ transplants, people with malignancy, and stem cell transplants, and on immunosuppressing drugs. Patients who are less than 8. Persons who have widespread skin disease are at risk of more disseminated monkeypox, so atopic dermatitis, active exfoliative skin conditions, pregnant and breastfeeding women, and complications. And this includes bacterial skin infections, bronchopneumonia, comorbidities, and gastroenteritis. And then their last one, which I think is probably the most commonly used indication for initiating tecovirimat, is people with monkeypox with aberrant infections that include accidental implantation in eyes, mouth, or anatomical areas where monkeypox virus infection might constitute a special hazard. And that includes, like Andreas was describing, proctitis, involvement of the foreskin with phimosis, intraurethral involvement, severe pharyngitis with poor oral intake, and then, of course, ocular involvement. So what are the options for treatment? They include tecovirimat, cidofovir, and brincidofovir, and then finally, vaccinia immune globulin intravenously. That one I'm not going to speak to very much. It's FDA approved for complications of vaccination. And really, at this time, cidofovir, as many of us know, has really unacceptable toxicities as regards renal toxicities. So that's an agent we love to try to avoid. It's FDA approved for CMV retinitis. Brincidofovir is much better tolerated. Its metabolite is cidofovir, but its main toxicity is GI toxicity. It is not, however, currently kept in the national stockpile and isn't available to be mobilized into action for folks now. Tecovirimat, thankfully, is well available in the national stockpile and has been mobilized extensively already. And the little bit of data we have suggests that it is very well tolerated. It was approved for smallpox, and many physicians say to me, if this was FDA approved, why is this so difficult now? Why is the CDC making this EA-IND so difficult? Why are we having to jump through so many hoops? They were approved as an animal-based medication. And so this type of indication really comes from the fact that it was supposed to be used for smallpox. There was no way to test efficacy in a human. So efficacy data is all coming from macaque and rabbit models, and safety data was in healthy patients. And so there really was no efficacy data in humans. And so because of that, this EA-IND process, when it first rolled out, was quite extensive and quite burdensome. And the CDC has revised it now 2 additional times. It is much easier now. There's an intake form and a consent, and then a closeout form where you describe all the things that happen during the course of therapy with tecovirimat. Tecovirimat is a potent inhibitor of the VP37 orthopox protein, which mediates the formation and egress of enveloped virions. It makes that protein that's on that envelope of the virus. In human primate and rabbit models, it looked very good. Let me show you a little bit of the data. So here, this is a very quick summary of the animal data for tecovirimat. There were 3 studies in macaques, and you could see treatment initiation with tecovirimat, day 4, day 5, or 6. And the percent who survived on placebo after being exposed to monkeypox were 0. And after being given tecovirimat, small numbers, but percent surviving ranging from 50 to 100%. In rabbit models, in 2 additional studies, again, small numbers, exposed to rabbit pox, no survival in the placebo arm and survival in the tecovirimat treatment arm of 88 to 90%. Does that prove that it's going to work in humans? Absolutely not. So what do we know about in humans? Well, they gave it to 359 healthy humans. 336 got the oral form, which is a capsule, and 26 got the IV formulation. They did quite well, and I'm going to review some of those relatively mild side effects in a moment. All we really have on data now, I'm going to show you over the next couple of slides. There definitely have been many case reports of people who had received smallpox vaccination and got disseminated disease, or had episodes of monkeypox before this epidemic and received tecovirimat. But really linking their response to anything was impossible with single cases. This data below comes from a series of 9 patients that were reported out by Adler and colleagues. 3 of them received brincidofovir, and I couldn't fit it all on the slide, but their graphs look very different from the tecovirimat graph. 3 people and 1 person, it's not a lot of data. This is the level of the data we have right now. So what you're looking at is the little dots represent the duration of rash in this client. Blood means that the monkeypox virus was picked up in blood, upper respiratory tract, urine, and here's the initiation of tecovirimat. So for brincidofovir, persistence of viral detection persisted for several weeks, and some of the other three. In the tecovirimat patient, they immediately dropped down their PCR detectability in these different anatomical locations. Rash cleared up relatively quickly, and the patient did very well on this particular regimen. The largest group of data that we have was published in JAMA just this month and summarizes their experience using tecovirimat at UC Davis between June and August of this year. They had 25 patients, 9 of them living with HIV. Median age was about 40. 1 had a history of smallpox vaccine, 4 had a history of Jynneos vaccine. Mean duration, 12 days of symptoms prior to treatment. 92% of them had genital or perianal lesions. 52% had fewer than 10. Complete resolution was seen in 40% at 7 days. 92% of lesions and pain resolved by day 21. And adverse events were real mild. Fatigue was seen in 28, headache in 20, nausea 16, itching and diarrhea present in less than 10. So the side effects that we've seen in those brief case series, and also in the 359 people that were given, healthy individuals who were given tecovirimat, primarily focus on a headache, nausea, abdominal pain, and vomiting. A few people did discontinue therapy, and that included reasons such as EEG changes, which were abnormal, stomach upset and dry mouth, fevers and diarrhea. 1 person did get palpable purpura and some facial redness, swelling, and pruritus. So how is this medication given? It is weight-based, and we do have availability in this state to get both the oral and the IV formulation of tecovirimat. The drug absorption when taking it orally is heavily affected by having a fatty meal. And so it's very important to instruct the client to eat a fat-containing meal within 30 minutes of taking their dose. Most of the folks weight-wise are going to fit into a 600 twice a day regimen. Some that are over about 120 pigs are going to need 600 milligrams 3 times a day. The IV tecovirimat cannot be administered in patients with severe renal impairment. There are some drug-drug interactions. The most common are listed here with diabetic drug, repaglinide, and midazolam, just showing a decrease in the midazolam dose, but more significantly an increase in the diabetic medications. And then for patients who are living with HIV, the most serious effect really being with patients who've been started on Cabenuva and reducing their relpivirine levels. And so it's recommended that you avoid starting Cabenuva even within 2 weeks of stopping tecovirimat, waiting for that metabolic change to go away. But if you're giving somebody Cabenuva and simultaneous tecovirimat, I encourage you to look at the Liverpool HIV interactions database. Consideration could be given to give an extra dosing via an oral route. So really what we don't know is over 400 people have been started on tecovirimat across the US, and we don't really know who are the right people to treat. Is it really changing their course of illness? And is there a time frame in which you can start this medication and expect to change the course of the illness? And so we really need a randomized controlled trial, and that is planned. So this is the study name, STOMP, that is being organized through the NIH AIDS Clinical Trials Group, and hopefully will be starting soon and giving us some of this data to better focus our therapy. Vaccination-wise, we have 2 choices, ACAM 2000, which is a live replication competent virus vaccine, and Jynneos, which is replication deficient, and therefore associated with a lot less toxicities. In Colorado, we've administered already 10,000 doses. What do we know about these vaccines? Again, not a ton. Past data from Africa suggests that smallpox vaccine is about 85% effective in preventing monkeypox. We have no data for Jynneos. We're looking at Jynneos and looking at its ability to create an antibody response and comparing that to what we've seen with ACAM 2000 and using that to infer how Genius will protect our clients. The CDC recommends the vaccine be given less than or equal to 4 days from an exposure to prevent onset of the disease. There's a little bit of data that suggests that that might work. If they end up getting a vaccine after 4 days from an exposure and before 14 days, there's still some hope that that will attenuate their course. After 14 days, you're really not looking so much at PEP anymore. You're looking at PrEP. So just to look at these contraindications for ACAM 2000 are considerable, whereas for Genius with that replication deficient vaccine, there really are very few. So a serious vaccine component allergy is the only real contraindication. For folks who have had an anaphylactic response to a quinolone or gentamicin, they may have some risk of having a reaction to Genius, and it's recommended that you monitor them in the clinic after the vaccine. Most recently, the CDC pulled out a study from 2015 and said, hey, we don't have to give the Genius sub-Q 0.5 milliliters. We can give it intradermal at 0.1 and make our vaccine last 5 times longer and really get more of our population vaccinated. This data, it's a small study, 524 individuals who are randomly assigned into lyophilized sub-Q, liquid sub-Q, or intradermal Genius administration. And what you can see is that essentially, looking across several different antibody measurements, that there was no evidence that there was a difference. There was non-inferiority. And when you look at antibody responses over time, we're looking at 2 different vaccines for the Genius, over one and then a month later a second. The antibody responses seem to hold across all of the different timeframes. And therefore, based on this, the CDC has recommended that we all move to intradermal. It's important to understand this study did not include anyone living with HIV or anyone who was immunocompromised or people less than 18. And so currently the CDC is making exception for people who have keloids. They're saying they shouldn't get an intradermal, or people who are less than 18 but have not made immunocompromised individuals an exception to this intradermal alternate dosing regimen. So for the vaccine strategy across the US, we initially started with the plan of PEP, post-exposure prophylaxis. It rapidly became clear that for many of the patients diagnosed with monkeypox, it was very difficult to identify who exposures were because of anonymous sex dating sites, and reluctance to provide data about their contacts. And so jurisdictions began to move to this PEP++ regimen, which is essentially looking to find the populations who might be greatest risk of having had an exposure, and not really calling that PrEP, but calling that PEP, because we're trying to select for the people who may have already been exposed to monkeypox. And so we are currently still doing that in Colorado. We're providing PEP and PEP++. The PEP++ rules in Colorado are anyone aged 18 years and older who has had close physical contact with someone who has had monkeypox in the last 14 days, gay, bisexual, or other men who have sex with men, or transgender, non-binary, or gender diverse people aged 18 and older who have had multiple sexual partners in the last 14 days, had sexual partners they did not previously know in the last 14 days, had a close physical contact with other people in a venue where anonymous or group sex may occur, and anyone identified by public health as a known high-risk contact of someone who has monkeypox. And so we're given this intradermal injection now, and stay tuned because Colorado is in the process of redoing their PEP++ criteria and making them broader and more gender neutral and more neutral to patients' sexual orientation and gender identity. So in wrapping up, clearly this is a global epidemic with clade 2B, currently predominantly occurring in men who have sex with men, but we need to keep a broad view so that we can make sure that we try to contain the spread. It's disproportionately affecting people of color. And unfortunately, our current vaccine efforts have been highly focused into white populations and have not matched the breakdown of how the disease has been affecting the communities that we serve. We need to have a very high clinical suspicion because sometimes there's a single lesion. I'll give you an example. I had a patient who is a person living with HIV who I was examining. He just had one, what looked like pustule right here that he was sure was acne. He had a single lesion and it was monkeypox. So we do need to think, keep it high on our differential, make sure we promptly use PPE to protect healthcare personnel. Test 1 to 3 samples, depending on what is appropriate for your clinical situation. Treatment is available and now relatively easily to access. And vaccines are limited, but should be more and more accessible in really the next week. So I'm going to hold there and open it up to any questions and invite Andres to come up.
Sure, we have some online questions. I'll throw it open to our in-person audience first. And maybe while we're waiting for a question from the in-person audience, if you can answer why now? If these disease has been out there for a long time, it's shown up in the US before, why is it now showing this more increased spread?
I think part of it is waning immunity. As we get further and further out from populations that have had smallpox vaccination, I think that's one of the issues.
Global warming, deforestation, global warming, deforestation, a lot of increased interaction with human and wild, and this kind of focus where this virus lives, that kind of also jumps for opportunities for viruses to jump in.
Thank you all for a really wonderful grand rounds. My question to you is about a symptom that I've heard is very common that we didn't talk much about, which is pain. Can you talk a little bit about why pain, and is this different from the former clade? Is there a sort of an affinity towards nociceptive fibers in particular? And then how does pain respond with respect to treatment with TPOXX? Is there resolution, or does it require a whole different line of management?
I think quite a bit of the pain is due to mucosal involvement. And so the majority of the patients, I think, that we've seen, that's been the case. Some of them also just very deep dermal involvement and pain. So we had a patient who had a lot of lesions on the hand that was having a significant amount of pain. So it's one of the primary reasons for hospitalization across the globe. So thank you for bringing that up. And it's definitely one of the primary reasons that we start tecovirimat. And I would say that the response is antidotally been quite profound. So most of the patients have some level of improvement within 2 to 3 days after starting their tecovirimat.
We have a question online regarding vaccine. There we go. Hello? Okay, great. Are more vaccines being released from the stockpile, or is vaccine production ramping up to the point that this may end up being a vaccine for the general population?
I think the total amount that they plan to get by 2023 is around 5 million vials. And so it would be very difficult for us to vaccinate the entire population. So I think currently most vaccine programs are still picking out risk factors that help folks understand if they're really at risk. And certainly there are folks that we have seen that are being described that have no identifiable risk, but that's not the majority of the cases.
You have time for one last question.
Great talk, Karen and Andres. Thank you. I had two questions about immunology in terms of duration and protection after natural infection. So I'm having a lot of patients asking me now that I've had monkeypox, am I protected for life? And am I at risk of getting it again? And then also currently they're not recommending vaccination for people who have already suffered from monkeypox infection. Do you expect that to change in the future?
I don't know if you know anything new.
Yeah, the expectation is obviously we're still learning is that it's going to be protective. You hear cases that potentially people having more than one infection. I think we're still learning that how immunogenic will be the infection and protective. But so far I will say that that's the good assumption. We'll have to see. And then the vaccines, I don't know if you think that will change. It depends on what we learn, I guess. That can change the recommendation for people who had the infection in the past.
Yeah, it's unfortunate. We don't know the answer. And certainly they're saying if you had a smallpox vaccine, but it was more than 3 years ago and you've had an exposure, they still recommend that you get the Jenius. They think there's enough waning of the smallpox vaccine efficacy. We've seen obviously several people that have had smallpox vaccine present with monkeypox. So I think we'd have no idea. And yeah, it's real hard to give that counseling message.
Great. It is 1 o'clock. So I just want to say thank you very much for an excellent grand rounds.